Welcome to ESOC 2022. It's a pleasure to be here. My name is Mira Katan. I'm a stroke physician at the University Hospital of Basel in Switzerland. And it's really my great pleasure to introduce Dr. Sven Poli, a stroke physician of the University Hospital of Tübingen in Germany. And more important, he's the PI of the eagerly awaited ATTICUS trial. Apixaban for the treatment of embolic stroke of undetermined source. So Sven, it's nice to have you here and talk about your great trial. And first of all, congratulations of the completion of the trial, this really important trial. So what inspired you? What was, what made you start this trial with your team? Maybe you can explain to the community, to the stroke community, your main hypotheses and findings of the trial, to give your own view on the topic.
So let me just correct one thing. So the trial was an interdisciplinary trial, and the actual PI is Tobias Geisler, who is cardiologist. I'm the co-PI neurologist. So we were conducting the trial together, planning the trial together. That's an important aspect of this and the spirit behind ATTICUS. What is important is that the optimal therapy of ESUS is still not yet established, and ESUS patients make about like 20%, 25%, depending on the cohort. And AF is supposed to be one of the major underlying causes of ESUS. And most importantly, two large trials enrolling all comers of ESUS patients were negative. So our hypothesis was to focus on an enriched ESUS population with additional risk factors for cardiac thromboembolism, including echocardiographic, electrocardiographic, and clinical additional risk factors, which makes it somewhat unique. There's another trial, Arcadia, ongoing that has similar approach. And what is specific in our trial is that we also use mandatory continuous AF monitoring. That is not the case in Arcadia. So we are not only selecting our patients, but also we want to detect AF and then get more insights on what is actually causing, or what are the real risk factors for new ischemic lesions or new recurrent stroke.
So that was like the background, the inspiration, looking for, selecting patients kind of on a precision medicine approach to identify those with the highest thromboembolic risks based on a cardiac disease. So if I understand correctly. And I think, also for the stroke physicians around listening now. So how you identify these risk factors? How do you select those then for the trial design to include your patients?
For selection of the enriched ESUS population, the patients had to undergo transesophageal echocardiography. We're looking for left atrial enlargement, spontaneous echo contrast, and left atrial flow, or better, low flow. They had to undergo 24-hour Holter ECG monitoring, and there we have been looking for atrial high rate episodes. Alternatively, a CHETS-VASc score, which was abused for risk stratification above or equal than 4, was a prerequisite for being enrolled in the ATTICUS trial.
So based on these selection, you really then guided treatment, obviously. So you did the one-to-one randomization, and you looked at the strategy giving directly Apixaban versus antiplatelets. So what was your main finding? So what was your main finding, main outcome points?
So we finally could not show a superiority of Apixaban in preventing new ischemic lesions on 12-month MRI. They were similarly distributed in both arms, 13.6% in Apixaban arm and 16% in aspirin arm, not significant. We had a high rate of atrial fibrillation detection, 23% in the Apixaban arm and 28% in the aspirin arm. It's important to note that all aspirin patients, so a third of these aspirin patients, were switched to Apixaban after AF detection. So optimizing the aspirin arm. So it's not a real comparison between Apixaban and aspirin, but rather a comparison of Apixaban to aspirin plus mandatory cardiac monitoring, in most cases with implantable loop recorders, and the switch. And clinical endpoints like ischemic stroke, TIA, systemic embolism, pulmonary embolism, and the composite endpoints, including death, was similar to in both groups. SAE were also similar, and major bleeds and clinically relevant non-major bleeds were also similar. The only difference was in minor bleeds. Yeah.
Very important point, take-home message is the safety of the study. And correct me if I'm wrong, but you started quite early, either aspirin or oral anticoagulation, and the safety looked very similar, which is also an important question, and maybe you can comment on that a bit as well.
Yeah, you're totally right. We started the study treatment in between 3 and 28 days, and the median was 8 days, so much earlier compared to RESPECT or NAVIGATE ESUS, indicating that early Apixaban appears safe, at least in this study.
So for now, the general stroke physician out there, what can we learn from the trial? What one do you want to, send out as main message?
So first, Apixaban is still not indicated in this population. So there's no official indication. So everything what I'm saying now is off-label. But the recommendation could be that you could start in ESUS patients Apixaban very early. Look for AF during a year with an implantable loop recorder. And then after a year, you may de-escalate to aspirin in case of no AF detection, or remain on Apixaban if in case of AF detection during that year.
And I think you also mentioned there are trials ongoing, such as the Arcadia trial in the US and the Moses trial in Europe, where they are based also on underlying cardiac or atrial cardiopathy, guiding secondary prevention, to really select patients who might benefit from oral anticoagulation versus platelets. And I think it's also important to say that we need to further investigate, I guess, and see what these trials will bring in that setting. So I thank you very, very much for your time, for being here at ASOG, for presenting this important trial. Don't miss it also. It will be online. You have to look at the presentation, the plenary presentation as well. Thank you very much, Sven, for being here.
Thank you, Mira, for this interview.